Hi, everyone. Today we're going to be talking about men's sexual health concerns during and after cancer treatment. We are blessed to have Dr. Stieglitz here, who is a urologist at Baptist MD Anderson, who's going to take the time to go into this topic. Dr. Stieglitz, thank you for coming, and I'm going to let you take it over.
All right. Thank you so much for having me, Heather. I'm very excited to share this with you guys. First thing I'm going to do is share my screen and take over the presentation. So give me a minute to get there. Share and all right. And Heather, what they're seeing is my slides, not the slides with notes, correct? All right. Hopefully, I'm still working out the Zoom stuff. All right. So let's talk about men's sexual health within the survivorship program. So wherever you are on your journey, this talk is for you. This is a little slide about me, how to find me. I'm actually a local girl. I'm from Jacksonville. I went away for lots and lots and lots of education and then found my way home, and I'm really happy to be back. So who's this talk for? It's for men. All right. Number one, this talk is for men, but it's also for your partners. Okay. Because one of the things you'll learn if you ever come talk to me is I want to know what your partner's role is. If you have one, if you don't have one, that's fine. If you're in between partners, whatever your story is, everyone has a different story, but this isn't a female sexual health topic specifically. This one is for men. Brothers, whoever you're talking to, your children, you might have gone through genetic counseling. You might have learned a lot about yourself and, your cancer and all these things along the way. So you don't have to keep this private. I also want you to really feel empowered by that because sexual health is part of your total health. And I really believe that. And just in general, some of the things that we're going to really focus on are, survivors. When I say survivors, I mean anywhere along your treatment. You are in this building. We are helping you with your colorectal cancer, your prostate cancer, radiation of any sort, chemotherapy of any sort, wherever you are along the lines of this. That's who this talk is for. So what are we actually going to talk about? We're going to talk about your sexual health. And there are really three main phases of sexual health. There's desire. Do you even want to anymore? Do you care? Is this important for you? And that falls into libido. Do you desire this? And then we also talk about the actual physical function. Do you have erectile function? Has it changed with your treatments? Has it been impacted by it? And not just being able to have an erection, but then what do you do with it? What your goals are, what you and your partner's goals are if you have one. And, more specifically, we'll talk mostly about erectile function and dysfunction. And it's important to think about it in these three different ways, because I'll tell you, one of the most unhappy patients I ever saw had gone through, had prostate cancer cured, eventually got a penile prosthesis, a surgery for erections, and he was miserable. He wasn't happy. We couldn't figure it out. He had $1 million workup. And then he finally sat down and said his wife didn't want him to have it and he wasn't using it. So he went through all of this and thought he would help restore his marriage, restore intimacy if he had a penile prosthesis put in, and she had no interest in it. So it's really important to establish what your goals are and what we're going to do when we get there, because we don't want you to be unhappy with what we do. And at the end, I'll tag a little bit into urinary incontinence because it is related to intimacy and some of the treatments that you may be going through or have already gone through. So let's talk about what erectile dysfunction is. It is the inability to achieve or maintain an erection firm enough for intercourse. So I might ask you different scales on a scale of 1 to 10. I'm not talking, can you get a 10 out of 10 erection? It's what you need to meet your goals. So I do want to make sure that I clarify that with you. It's actually more common than you think because I don't think people talk about it. About 1 in 5 Americans, that's 20% of Americans over the age of 20 have erectile dysfunction. And then by the time you hit age 40, it's half. And this is just a regular American guy. This isn't someone who's had a cancer diagnosis or had chemotherapy. These are just regular guys. The overall number is about 39 million men. This just shows you sort of the biology of erectile processes. So on the left, you see a flaccid state penis, on the right, erect, and everywhere in the middle, you see arteries and veins. And the two little yellow tubes on the top are nerves. Erection is a process of vasculature and of nerve tissue. And just a little plug, if you can get your COVID vaccine, COVID interacts on receptors that line blood vessels. And it's not specific. It's not just blood vessels in your heart and in your lungs. It's blood vessels everywhere. And we have found COVID in penile tissue of patients who have had COVID. So keep your erection safe. Get your vaccine if you can. I know some people listening might not be able to, but that's my little COVID plug. All right. When we talk about erectile dysfunction, it has a huge negative impact on your quality of life. And we talk about common causes. The most common cause is going to be vascular. All right. So heart disease, plaque, those sorts of things. Second most common is going to be diabetes. Diabetes is a disease of small blood vessels, we say. That's why diabetics can lose fingers and toes, because of the small blood vessels. Well, your penis also has small blood vessels, even if you might not want to acknowledge that, but they're much smaller than the blood vessels in your heart and in your legs. So it is a disease of small blood vessels, and it definitely can affect erectile function. And then the third leading cause is medication. So, put all these together. A lot of these can be side effects of treatment you've had, surgery, of chemo, of radiation, and plus you might be on medicines that are also contributing this to you. So what else besides that? Stress. We're seeing, urologists are seeing a lot of erectile dysfunction in young patients in the pandemic, and we're really attributing it to lack of access to doctors and anxiety. There is like global anxiety and depression right now. And if you are stressed, if you're not in a good place mentally, then like that's where erections and libido and sexual desire sort of starts. It starts in that brain. I always correct people when they say I'm a neurologist with an N. I say, no, it's the other brain. But right now we're talking about this brain, because if you have all this weight on your shoulders, you're not going to make time for intimacy. That's not going to happen. You can't just put all those things away real quick, file them away, and then be intimate with your partner and then come back and be stressed again. You have to work on your life balance. And the number one medications that are going to cause erectile dysfunction, antidepressants and hypertension medications. And I'm sure maybe more than half of you watching this are on one, if not both of those. Because we just talked about it. The whole world is anxious and depressed right now. And then if you're fighting a chronic illness, if you're fighting cancer, if your loved one's fighting cancer, you're going to be on an antidepressant too. So sorry, doctors are trying to help you, but sometimes this stuff doesn't help because it hurts other things. I'm just going to show you these. We're not going to go through all of these, but if you pull up a comprehensive list of medicines that can cause erectile dysfunction, I think I have 4 slides worth of medicines. The first on this slide is the huge class of antidepressants. And on the bottom is a huge class of other drugs that treat different mental health disorders. There's all these drugs for your heart, for your cardiovasculature. There's some antibacterials, more heart medicines. And then on the very bottom of this screen, anti-neoplastic drugs. We can't even list them all. All the chemotherapies can contribute to this. And we don't even know about immunotherapy yet because it's so new. But I imagine that's going to be on this list one day too. And then all these other things, these allergy pills, these other hormone things, pseudoephedrine, naproxen, all of these medicines that you really wouldn't think twice about can contribute to erectile dysfunction. I'm going to segue specifically for a minute into patients who have survived or along their care for prostate cancer treatment. This is a really neat schematic. You have this beautiful picture with the bladder on the right, the prostate in the middle, the sphincter on the left. So to the left, the rest of the sphincter, that goes out, the penis, eventually where the urine comes out. The bladder goes more towards what's inside the belly. So your surgeon's going to cut out that prostate if you've had a radical prostatectomy, and all those yellow tubes with little fingers on them at the bottom, those are the nerves, arteries, and veins that also go down to your penis, to the erectile tissue. And so even if you have a complete nerve spare, you can imagine us going down there and getting those nerves off. We don't have a microscope. We're scraping it. We're doing the best we can with the robot or open, however you've had your surgery. But those nerves, if not damaged permanently, they're going to be moved, they're going to be bruised, they're going to be really irritated. And then we sew it back together. We take out that prostate and we sew it back together, the best we can, trying to spare those nerves, arteries, and veins. But there's no way they're getting through that untouched. You could have the best surgeon in the country, in the world, and he or she is not going to untouch those. And, when you think about it, you want the cancer gone, right? So you want them to get that prostate out, and then you're going to deal with the rest of it. That's why you're listening to this talk, because you want to live long enough to be able to get back into the bedroom and, to have as much of a normal life again as you can, but you got to cure that cancer first. So you don't necessarily want your surgeon thinking, oh, can he get an erection again? I'll leave this corner of prostate here. You want him to take it all out. But then we got to figure out how to help you when you're done. The numbers say the sexual dysfunction after surgery is 25 to 75% of men. And I'll tell you, it's going to be closer to the 75% mark. And it's not because the surgeons vary, but it's because when they ask these questions, some men might not be having sex anymore. So they're not going to really say they have sexual dysfunction. You can gear a survey to get answers however you want. The reality is it's like 50 to 75%. And even if you had a 10 out of 10 erection before surgery, it's never going to be that strong after surgery. You might get a 7 or 8 out of 10. And most guys, by the time they're having surgery for prostate cancer, their erections are already down to a 6 or 7 out of 10 anyway. And then we're going to talk about radiation also. Radiation doesn't have the same shock factor where you just take that prostate, cut it out, send it to pathology. But over time, it's in the same area and it's going to affect that nerve tissue. It's going to affect that erectile tissue. And up to 50% of men after radiation will report erectile dysfunction. And it's usually not immediate. It's a slower process. So what can you expect after you've had prostate cancer treatment? After surgery, you can expect your penis to be shorter. This isn't necessarily related to erections, but this is what you can expect. And if you've had the surgery and you noticed it, you're not going crazy. The penis is shorter. When you cut off its blood supply, it's not going to be as robust as long as it used to be. Erectile dysfunction, we just covered that. Lack of ejaculation. So even if you have erections again, you don't have a prostate, you don't have seminal vesicles. So the anatomic places that semen comes from are gone. So you can still orgasm, but nothing's going to come out. And I just want to make that really clear. There's 3 phases when you talk about orgasm. There's getting an erection, there's having an orgasm, and then there's ejaculation. And those are 3 separate things. And you don't have to have an erection to orgasm, and you can orgasm and not ejaculate. And so it bothers a lot of patients. And what I try to tell you guys is, if you're not trying to have a baby again, then it doesn't really matter. That's what the purpose of that is for. So if you don't have the seminal vesicles in the prostate, there's not going to be any fluid, but you don't really need it anymore. But what some guys will have is you will leak urine. And that's another complication of, not really complications, kind of what happens with this surgery. So you can orgasm and some urine might come out, and that's part of just a pelvic floor spasm of what orgasm is. And what about if you've had radiation for prostate cancer? Like I said earlier, erectile dysfunction, but it's going to come along usually more slowly. Sometimes guys will also say that they've lost ejaculation, but again, you should still be able to orgasm. And I've got this wonderful book. I don't have it in here. I'm in my office. It's in my clinic, written by a PhD who specializes in sexual function in men after prostate cancer treatment. And he explains to you that the orgasm is different. He explains what it's like. It's just this really great book that can give you a lot of hope, a lot of information, because people don't really talk about this. But you can still orgasm. And so you're not going to lose all of your sexual life after you've had your prostate cancer treated. And then chemotherapy, androgen deprivation therapy, if they're killing your testosterone, your libido is going to go down. You're going to be tired. Some guys get what we call menopause. They get menopause symptoms because of the hormone changes. That's going to be more of a result of if you have to have other therapies besides surgery and radiation. And these, if you don't have any testosterone, if you're just on hormone therapy, you definitely could have some erectile dysfunction. So I'm sure you all want to know, how can I prevent this? How can I fix it? And there is actually something called penile rehab, and it's not data proven necessarily. There's lots of urologists who are doing this. They want to do this. They're interested in it, but we have not found the perfect algorithm for success yet. But there are different versions, but basically it involves pelvic floor physical therapy. If you had that before your prostate treatment, great. If you haven't, sign up. If you've already had your prostate treated, go to pelvic PT. Her name is Jana. She's in this building. She's amazing. This is so good for you. It's not a hoax. Penile rehab involves pelvic PT. It involves a vacuum erection device and daily Cialis. And the thought is to strengthen your pelvic floor with PT, to learn to relax it if you need to. You don't know how to assess your own pelvic floor, but Jana does. And then to do a daily vacuum erection device, which basically will pull blood into your penis, into that erectile tissue, and daily Cialis. I swear that's like the best antidepressant for men. It's not used for that purpose, but I have so many men on daily Cialis, and it increases blood flow, helps you pee better. It's very, very minimal side effects, if any at all. And it's just a great medicine. And it looks, the process looks something like this. You create an erection with the vacuum device and you hold it in there for like 1 to 3 minutes, and then you release it and you repeat it. So it's basically doing like a penis exercise, putting your penis on stretch, you're bringing blood flow into it. And again, there's, and I took this off of someone's website. At the very bottom, it says there's no guarantees. It may prevent significant length loss after pelvic surgery. So this isn't just prostate surgery, it's just pelvic surgery in general. And we're going to get to that in a minute. But I'm telling you, guys feel better when they do this. So it's not a silver bullet. It's not a magic process. But I think we're going to get better and better, urologists are, at knowing exactly what to do to really help you there after you've recovered from these surgeries. So then we'll segue into colorectal cancer treatment. This is a picture of a pelvis, and in the bottom you can see some bowel. They have a little very tiny thing. It looks like a little almond or something. They're labeling it as the prostate, and all that yellow stuff are nerves. And then the stripy red things are pelvic floor muscles. And just think, if you've had your colon operated on, where it's somewhere in the pelvis, and not all the colon is in the pelvis, this is rectum, this is sigmoid colon. Look at all those yellow nerves that are in the way. So again, you might have the best colorectal surgeon in the world. You had a perfect surgery, but these nerves are going to get touched. They're going to get moved. They might get cut. It's your anatomy, and they're right there. It's nerves to the bladder. It's nerves to the pelvic floor. It's nerves to your thighs. It's nerves to your penis. It's nerves to your prostate. It's all of them. They're right there. So if you've had surgery, several nerves at risk. And if you've had radiation, it's in the same area, and several nerves are at risk of being in the way or just being, taken in the process. And when we look at it in reported studies, they say after, colorectal surgery in general, up to 75% of patients report erectile dysfunction, but in the majority of them, this goes away. So it's not like the prostate that's like being cut and sent to the lab, and like those nerves, there's definitely pieces of nerves, and, they're not, nerves can heal over time, but, if you've taken this much, it's not going to find its way back. It's not going to grow back together. But in colorectal, if they're scraping nerves away, they're going to recover from that. They have a better shot, I think, just based on the different techniques. And the numbers in the colorectal literature say that about 3% have permanent erectile dysfunction. So the difference here is it usually does get better over time. But that being said, I certainly have a group of men in my clinic that I have helped with this after they've had colorectal surgery, because it didn't get better, and they're happy, they're functioning again. So there are lots of treatments for you. We're going to get there. I get too excited. I get ahead of myself. So after surgery from colorectal cancer treatment, you can expect a large percentage have erectile dysfunction. I don't know the numbers, it's not well reported, but they'll have retrograde ejaculation. There's a group of nerves that are deep in your pelvis that are responsible for ejaculation. And if those nerves are taken, if they're damaged, then again, you either can have retrograde ejaculation where it comes out, but it goes into the bladder instead of coming out the end of your penis, or the ejaculation doesn't come out at all because the function of ejaculation has been damaged. But again, people call it dry orgasm. If you're not trying to conceive, then this isn't something I want you to really dwell on. But this is something we take into consideration when we counsel men in their 20s and 30s when they have to have deep pelvic surgery. We talk to them about sperm banking, because if they lose this ability for the ejaculate to come out, then they're going to have a hard time. It's going to be pretty difficult to conceive. So when they're young, we talk to them about that. And that again would go to infertility for the younger guys. And then there's also a rate of urinary retention. If those nerves in your pelvis kind of go into shock after surgery, there's a chance that you don't pee, or you don't pee well. Your bladder is a muscle, and if the nerves to your bladder are disrupted, it's going to be hard for you to pee. So I've also seen patients after this who are in urinary retention. They can't empty their bladders all the way. And for most guys, that also recovers over time. But again, it's nerves, and nerves take a long time to heal. And then radiation with colorectal cancer, again, slower development of erectile dysfunction, and any of the chemotherapies that you might need for colorectal cancer can cause decreased libido. Sorry, you wouldn't get androgen deprivation therapy with that. I think that was a carryover from before. So now that we've basically said any sort of surgery or radiation or chemotherapy you've had can really crush your bedroom life, let's talk about how to fix it, okay? You might have seen these clinics, you might have gone to these clinics, you might hear them on the radio around town. There are therapies called shockwave therapy, there's stem cell therapy, and there's platelet-rich plasma therapy. The American Urologic Association and the Sexual Medicine Society of North America, which is a branch of the Urology Association, we don't recommend these right now. There's not enough data to support that they work. The one that I'm watching the closest is the shockwave therapy one. And when we've decided this actually has positive outcomes for patients, it's actually doing things, then, I promise I'm going to try really hard to bring it here. But right now you can go pay cash for this, but it's not recommended by my societies or guidelines. So I just want you to proceed with caution. I also want you to consider, if you're going to have someone manage your sexual health, it should be a urologist. It just should. This is what we do. So that's my little plug here. Be careful. You could pay a lot of money and have these things done to your penis, but I'd rather you protect it, not do anything investigational. So let's talk about the real treatments, the ones that we offer here, the ones that are endorsed. We have lots of good data, good studies. These are safe. We've got simplest oral medications, Viagra, Cialis. You've heard of these. I do have a lot of men on injection therapy. I have some men who are worried, those with who are still on chemo, who are worried about an injection and infection, who will have the injection ingredients, but as a gel that they put inside their urethra. That's new. It's not on this slide. There's vacuum devices we talked about. There's suppositories. So that's like a sort of a pill that would go into the urethra, but I also have a gel. And then there's penile implants. The Cadillac of all of these treatments would be a surgery. So easy PDE5 inhibitors, Viagra, Cialis, Levitra, they basically increase blood flow to the penis. I can't really tell you how effective they are because it really depends on your story. Most common side effects are going to be headache, visual changes, because they work on blood vessels. So if they do that in your head, sometimes you just don't feel good. You can't do these if your heart's not strong enough. You can't have these medicines if you're on nitro, if you have a prescription for nitro for chest pain. Men who have diabetes are more likely to not respond to these or to fail them quickly. Once you do start these, there's a really good chance at some point they're going to stop working. That's just the way these work, is the progression of the erectile dysfunction. But that being said, I have a lot of men who take Cialis daily as a penile rehab, increased blood flow. It's a really great medicine, but then they'll need something extra for when they're ready to have intercourse. So I have a large cohort of men on this, and bear with me. This is injection therapy. So the pills require you to take the pill. You wait an hour or two for it to work. If you ate a heavy meal, you're not going to get the full effect of the pill. It doesn't work every time. The injections bypass that step, and it's basically a medicine that works right on the blood vessels in your penis that you inject right into your penis muscle. It's a tiny needle. It's like a little insulin needle. So diabetics usually are like, I'll do it. I inject myself all the time. Pain is not really a reason people stop. The needle's so small, and it works almost instantaneously. So within 5 to 10 minutes, I order different samples of this. We pick your best dose. We teach you how to do it. Guys who stop this are either like, all right, I'm ready for the penile implant, they're ready for surgery, or they're just tired. You have this little pack, you carry it around, it's a little more spontaneous than taking a Viagra because it works pretty quickly, but it's still not spontaneous. So it's a really nice middle ground when you need another step besides a pill, but you're not ready to go all the way for surgery. It's a vacuum device. We talked about this in the context of penile rehab. Vacuum devices are good. It really takes the right patient, because what you do is you put this thing on, you suck all this blood into your penis, and then you put basically a rubber band at the base of your penis. So for some guys, it'll turn numb, it'll turn cold, it's sort of painful. So this is good maybe if the medicines don't work, maybe your hands aren't really steady enough to do injections, or you're worried about infection. If you're immunocompromised, it's a nice middle ground, but it's not the best. There's a pretty high rate of discontinuation because of pain. And if you're on any blood thinners, you really shouldn't do this, because you'll get a lot of bruising. We call it an eggplant penis. You don't want your penis to look like an eggplant. Let me talk about suppositories. Suppository is basically one of the ingredients of the injections, but you put it as a little pill inside your urethra. It's a little weird to do that, I'll be honest with you. And when it absorbs through the urethra, the number one side effect is pain. Not all guys have that, but that's just the number one thing that people say. And sometimes they worry about that going into their partner. There's not really much of a problem with that, unless their partner's pregnant. You can't do that. But it's an option if you can't inject. I also have the injection formula as now a gel that you would also squeeze into the urethra. So it's not a pill, it's a gel, and they're not having the pain as a side effect. So those are interesting options. I've got some guys who are on that and they're having mixed responses, but it's also, everybody's different. So they'll respond to different things, but it's a nice step to consider. And then there's the penile implant. So this is a surgery. It goes into your body. No one knows it's there unless they touch or feel for it. And you get a button in your scrotum and you get an erection every time. So 6 or 7 pumps and you have an erection, lasts as long as you want. And then you release it and it goes back down. It is a surgery. It's 2 hours long on average. It's not a long surgery. And it's basically the most effective you're going to get. It's the closest to a natural erection you're going to get again, because you can do it yourself, pump it up in like 6 pumps. You don't have to wait for a pill, wait for an injection, do it whenever you want. And there's not, if you're considering one, we would have a long talk in clinic about side effects and potential complications. But what I basically want you to know in this talk is that it's available. We use this a lot after prostate cancer, definitely after some colorectal cancers. So you can have this even if you've had surgery and radiation. So it's implanted with an antibiotic coating on it, which really decreases infection. They've been in use for over 45 years. So believe it or not, this is not something brand new, although this current model I'd say is the Cadillac, and we definitely have come a long way in developing them. And more than 500,000 men have one. So think about that. There's a really good chance that you know someone or know someone who knows someone that has a penile implant. I tried Googling this once to try to find celebrities with them. I found some really fascinating stuff. So this is just going to walk you through it. As long as it plays, I might have to advance one more. Okay, here it goes. This is a drawing, a cartoon. It's not an actual penis, although I do have a video and I have a model if you want to see it like in a real human. So the rods are inside the two penile erectile muscles. All right. And then the pump is moving fluid. There's a little balloon that goes into your pelvis right next to your bladder. It moves fluid from there to the cylinders until it's as hard and firm as you want it. And then there's a release button and it automatically cycles back. And that's how the penile implant works. People are really happy when they do this. A lot of guys are scared of another surgery. But when you're tired of relying on a pill, when you're tired of relying on injections, or if they don't work anymore, this has like saved relationships, saved marriages, saved, self-confidence, that like feeling of being able to accomplish something. It's a very satisfying thing that I get to offer my patients. So then a couple minutes about leaking urine. And again, this can happen after any of the things we've talked about today. So stress incontinence is when you leak if you cough, sneeze, swing a golf club, take a couple steps. It's not the, oh, I gotta pee, I didn't make it to the bathroom in time. It's there's no physical holding in of your urine anymore. This is about 10% of men, and it increases when you hit age 60. The thing about erectile dysfunction is I have found a lot of men figure it out. They're like, you know what? My partner and I decided it's not part of our life anymore. It's one of those things that they kind of just write off. They're done. They had a lot of fun in their younger years and now they're done with it. And I still love to be able to give that back to them. It's still very rewarding. But leaking urine stops men and women, but we're just talking about men in this talk. It stops men from going to restaurants. I had a patient who was almost crying in my office because he accidentally leaked urine on himself, and his granddaughter said, like, "Grandpa, you smell like pee." It's this really like this life-changing thing that you have no control over. And I love being able to help men here because this really makes you feel better. The number one cause of this is going to be taking a prostate out. And again, it's not because you had a bad surgeon, it's just the nature of the operation and where that stinking prostate gland is. It's in the way of all these important things. For the 70,000 prostatectomies we do every year, up to 16% of men are wet permanently afterwards. They're all wet for a little while as it heals, but we usually give them 6 months to a year to say, all right, at this point, you're not going to get any better. So then what do we do next? Guys will be like, oh, I don't drink anything. I dehydrate myself. I have to pee every 20 minutes so I don't wet myself. People do that. We send guys again to pelvic floor physical therapy. Jana can really teach you how to strengthen your pelvic floor muscles, because when your prostate's gone, you really need that pelvic floor to support everything. Kegel exercises, biofeedback, and then, what are you going to do? Pads, catheters, condom catheters, ones that look like condoms and slide on the outside and collect the pee. Penile clamps, this sounds barbaric, but it's actually, it's soft and it just pinches the urethra closed and you take it off to go empty your bladder. It's a really interesting option for certain patients, and we have several in my clinic that we can trial. Gold standard treatment is going to be a surgery. I'm not here to sell you surgery. I'm just here to tell you don't have to live like this. But it is an artificial urinary sphincter. So naturally you had a sphincter really close to the prostate, either the nerve to the sphincter got damaged, the sphincter itself got damaged, something happened. This surgery basically puts a fake sphincter back in. Here again is a picture. You've got this balloon that goes around the urethra, another pump, and then another cylinder in your pelvis. A pressure balloon in your pelvis. You can have both pumps. I have patients who have a pump for their sphincter and a pump for their penile implant. So you can have both. And what it does is, I will narrate this video again. The balloon stays inflated around your urethra. So it pinches it off so the urine can't fall out. And so there's the urethra right in the middle, it's between the two erectile bodies. There's the balloon around it. When you push your pump, then the balloon deflates. The water, it's just one push. The water goes back into the balloon or in your pelvis, and your urethra opens and the urine comes out, and then it automatically closes again. So this one's even easier to work than the one for erections. The numbers are great here. 95% of patients are happy, 90% long-term. If anything, you got to think about it. If you're 75 and we're putting a sphincter in you at age 75, do you still want to worry about pushing that button every time you pee at 85? I think that's where that number comes from, why it's not 100% are satisfied long-term, because I imagine if you get more frail, if you have trouble with hand-eye coordination, maybe it just gets annoying in the future. 90% of guys overall would have it again, and 94% would tell their friends to get it. So these are all fantastic numbers. The happiest patients I have are guys who have had the artificial sphincter put in because they were just wet. They wouldn't go outside, wouldn't leave the house. This is a really great option. And there's a picture of me, phone number. I think that's the Baptist main line. You're welcome to come talk to me in clinic. You're welcome to do telehealth with me, whatever you want. We've got really great treatment options for you, and every patient is different. Everyone has a different story and different goals. And if this is what you want to do next, then you are welcome to come, and we'll get you as far as you want to go with your goals. Thank you for listening, and I hope you come meet me.
Hi, Dr. Stieglitz, a few questions. Thank you so much for your talk. One question is there any prehab options prior to treatment that can help with these symptoms?
Yes. So and the caveat to this is I'd have to talk to Dr. Melquist and Dr. McCormick. I've got two partners. So I don't do the surgery for prostate cancer. I was trained to do it, but I let the boys take over that surgery. But they talk to their patients about going to pelvic floor physical therapy before having their prostates removed. And if I have a patient I've worked up to that point, I also encourage them strongly to do that. Most of them don't. They probably just have too much on their plates, or just, there's a big mental block when you're about to have surgery. But going to pelvic floor PT before surgery is a great option, and we have it here at Baptist. So you should take advantage of it.
And is that something that you would recommend doing before the artificial pump as well?
No. So not before. By the time they see me for either the penile implant or the artificial sphincter, most of them, it's so severe that at that point, pelvic therapy is not going to help. Most guys have already been to pelvic therapy by then also.
Next question. How soon after surgery or cancer treatment can I have sex?
Okay, that's going to depend on what surgery or what cancer treatment you had. Most guys, it's going to be 6 weeks. Okay, that's probably the most universal answer for you.
And is there any length of time that's too long to wait to see you? Like 10-year survivors, things like that.
I put the last patient I put a sphincter in, 15-year survivor of prostate cancer. So no, it's never too late. And it's also never too soon. So I've got a couple of guys that have come to see me before they even started treatment, just to say, what can I expect? What's this going to look like? And they bring their partners in with them. I think that's very informative for patients. And now we have this talk that'll be, published. They can watch it whenever they want. But sort of setting expectations, because that's also a really neat conversation to have if you want to, before you even, or while you're in the middle of things.
And one more that is often asked of me, actually, does neuropathy affect bladder incontinence and erectile function?
Oh, it definitely can. When we think about neuropathy, we think about fingers and toes and legs. And I don't have a perfect study or like randomized controlled trial to say if you have neuropathy in your feet, then it's also in your bladder. But it's nerves that are responsible for all of that. So if I don't have another reason to explain it, then I'm definitely going to say that this is neuropathy. Diabetics have different bladders in general, and diabetics have neuropathy. It's just the process of the disease. So the answer to that is that's a definite yes.
Awesome. Well, Thank you so much. As you said, this is going to be published for all of our patients to see, and we can navigate them to it in our clinic as well. So they have, if their family member or their partner's not able to go, they can definitely refer back to this discussion. I think it's so incredibly important. So thank you.
Yeah, thanks for having me, Heather.
You're welcome.